I think this was a great presentation by our colleague, Dr. Weiss-Draper, and she was able to look at different subsets of patients who got different treatments like chemotherapy, chemoimmunotherapy combination, radiation therapy, endocrine therapy, targeted therapy, and see if there is any correlation with mortality from COVID-19 in those patients who got different anti-cancer treatments. I want to point out that both my presentation and Dr. Weiss-Draper's presentation from the CCC19 were confounded, by different selection confounding biases that can happen in a retrospective study like this. So it's very difficult to come up with strong conclusions. However, we were able to identify some signals, and those signals of prognostication, I would say, are relevant, and I think set the foundation for future analysis. And I think it can inform, at least indirectly, discussions among different providers and patients. One of the signals that we noted that patients who recently received the combination of chemo and immunotherapy, the chemoimmunotherapy combination within the last 2 weeks, those patients have higher chance of dying, higher mortality compared to patients who did not receive this combination within 2 weeks. Obviously, this does not mean that there is a clear causation between chemoimmunotherapy and death, not at all. This can be confounded by other factors, but it was interesting to see that there was some correlation there that needs further investigation. Why this happens is that the case that those patients are sicker and they may die because of other prognostic factors. And we're going to look into those different parameters in multivariable analysis with more granularity in future publications in order to shed light into this mortality association with different prior therapies and different prognostic factors. In that context, my presentation identified older age, male sex, progressive cancer, poor performance status, multiple cancers, multiple comorbidities, also any recent therapy within 3 months, and all of them negative prognostic factors in patients with cancer and COVID-19, meaning that the presence of those factors, as well as black race and history of smoking as well, all of those factors were associated with higher 30-day all-cause mortality. And again, this association does not mean causation. However, I think we should delve further and to identify why this association exists, and those characteristics were associated with higher mortality in patients with cancer and COVID-19. It's very difficult to make any specific implications on cancer therapy. My opinion still stands that if someone, a patient, needs treatment for the cancer, especially life-saving treatment or important that is needed for immensely needed for palliative intent, these patients should go ahead and get this treatment, because cancer by itself can be a cause of death and can cause mortality. So personally, I have not delayed treatments in patients who need treatment when they have cancer during a pandemic. However, as I mentioned, this has to be individualized patient to patient, depending on the disease, the cancer control, and the acuity of the COVID-19 infection, and how symptomatic this is, as well as the capacity and bandwidth of the healthcare system in general. The last point to make is that we looked at the specific laboratory variables, and we found some associations between low lymphocyte count, lymphopenia, as well as neutrophilia, neutropenia, thrombocytopenia, as well as abnormal creatinine, abnormal D-dimers, abnormal high sensitivity troponin, and abnormal CRP, C-reactive protein, with mortality. So those abnormal labs were associated with higher 30-day all-cause mortality in the subset of patients who had these labs available in hospitalized patients. So we're looking further into these associations, and we'll try to come up in future publications with very granular data, and we'll try to also improve the quality of our data input to be able to share the data with statistical vigor in the near future.